Good afternoon, everybody. During this difficult period of COVID era, I try to make my presentation as much interesting as possible. And so, in the next course of 1 hour, I try to make it very elaborative and useful to you all. My topic is management of pneumonia. As you all know, sorry, I have a small problem here. Yeah. Pneumonia is an infection in the alveoli leading to accumulation of inflammatory exudate. Filling the alveoli, so there is a retardation or impairment of gas transfer across the alveoli. So this is caused by infection. This bacteria, as you all know, and there are viruses as well as fungi. So currently we are facing this viral, epidemic of this corona, as you all know, COVID-19 virus, so which we can, take it as a very serious problem. Currently, entire world is facing. If we consider the symptoms of pneumonia, as any infection, it gives rise to fever, cough with expectoration. Here the sputum can be just simply colorless, or it can change the color to rusty brown sputum or purulent sputum, which is in the form of opaque or yellowish sputum or brownish sputum. They also develop difficulty in breathing and with pleuritic type of chest pain. The reason for the pleuritic type of chest pain, as we know, is due to inflamed pleura over the infected lung. So that's called pleuritic chest pain. The pain comes on breathing. They also can develop palpitations, which is as a result of arrhythmias, as a complication sometimes. The commonest arrhythmia can be atrial fibrillation. In some cases, especially in the elderly, it may lead to confusion. So what are the signs? Basically, the respiratory rate will go up. So patient has to breathe fast in order to compensate for the compromised respiratory impairment. Also, they develop tachycardia maybe due to fever, maybe due to pain, anxiety, and all those reasons will lead to tachycardia. The chest movements can be diminished because of the reason of pleuritic pain on the side of the inward lung. Also, they have impaired percussion note in the form of impaired even to the dull state as a result even of development of a pleural effusion, which is a complication of it, which we'll discuss later. The pathognomonic sign of pneumonia, which is leading to the consolidation of the lung, gives rise to the physical sign of bronchial breathing. Hope you all know what is bronchial breathing, which is the pattern of breathing which is not vesicular, which has the expiratory component of respiration being prominent and louder. And there's a wide gap between the two sounds, as you all know. Crepitations are also a significant sign, which is elicited in the form of forced crepitations because of the fluid-filled alveoli opens up with the sound of crepitus. There can be a pleural rub as a result of pleurisy, which I mentioned earlier. How do we diagnose? Basically, when we suspect this, the straightforward investigation will be chest radiograph with other lab investigations, including hematology. So this is a chest X-ray of a person with a pneumonia, which is shown here with, you can see there is a right apical consolidation. There's a small cavity, so pocket of air we can call it. And also there are lines running across. If you see, I wonder whether you can see it, pick it up carefully. Try to see this air bronchogram. This is the air bronchogram, right? As indicated. So this is again a pathognomonic sign in the chest X-ray of consolidation. What are the other laboratory investigations? The basic investigations are like ESR, the inflammatory markers, CRP, and the full blood count. If it is a bacterial infection, bacterial pneumonia, invariably there will be a leukocytosis of neutrophilic type. Neutrophils will be raised and the white count is invariably high. Blood urea, electrolytes are also important points in the lab investigations, which will indicate the prognosis of the illness as well as severity of it. As well as the liver function test, as mentioned, because some pneumonias can lead to liver impairment, especially the mycoplasma pneumonia, which has extrapulmonary manifestations. We also can undertake blood cultures, sputum cultures, in order to isolate the organism from any of these fluids. Pathogen-specific tests, such as pneumococcal urinary antigen, which is not available freely to us in this country, but that is one of the accepted tests which are available in some places. Klebsiella PCR for the Klebsiella pneumonia, and the Chlamydophila antigen for the atypical pneumonias of chlamydia, which are relatively rare pneumonias. So we'll leave in that investigations part. We are coming to the important classification of pneumonia. What are the pneumonias which come across? Commonly, we discuss pneumonias in the form of community-acquired pneumonia. Then we have the next category, hospital-acquired or the nosocomial. In the hospital, how someone would acquire, especially those who are in the intensive care after respiratory intubations, endotracheal intubation, they can develop pneumonias. For prolonged recumbency, being on bed for a while, they also can develop hypostatic pneumonias and aspiration pneumonias. So these are most likely to be called hospital-acquired pneumonias. Then we have another category of pneumonia, which I am coming to, the pneumonia of the immunocompromised, which is the commonest type will be nowadays what we have in the form of HIV/AIDS related pneumonia. So it is the HIV infected person having the pneumonia. These pathogens are peculiar because they have immunocompromised status and they are susceptible to certain types of organ pathogens to cause pneumonias, which we'll discuss in a while. The other reasons for the immunocompromisation will be like people with organ transplantation or immunosuppressive therapies, with malignancies, especially blood malignancies, leukemias and lymphomas types, and also people with cirrhosis as a result of alcohol abuse or otherwise, as well as people with diabetes mellitus and the chronic kidney disease, and somebody whose spleen has been taken out. So they are called asplenic people. The rare type of pneumonia, also called geographic pneumonia, which will be seen in certain parts of the world, which is not commonly seen in people who travel to these locations like underground or the caves, which are inhabited by bats and all. And that is called, a good example is histoplasmosis. Histoplasma capsulatum, the organism. And so those who have got explorers who go to these places can develop this type of pneumonia. what will happen to the person with pneumonia? If you take this pneumonia severity score as shown by the NICE guidelines or the British Thoracic Society guidelines, we have what is called curve 65. So each letter and the number 65 to indicate the age of the patient to be 65 or more. You have 1 point, the C for confusion, U for urea, respiratory rate more than 30, and the blood pressure, the B. So when there's hypotension, that is again you get a 1 point, which is an adversely affecting the recovery or the uh, prognosis of the pneumonia. So we have the curve 65, which is very important classification to remember. And so what will happen with the curve score? If it is 0 to 1, that is called low severity, the risk of death will be less than 3%. So the chances of dying are very less. So these people can be taken as low severity or the good category people who can be managed even at home or at the institution with minimal amount of support. They get better. Then the curve category score of 2, you have a moderate severity with the risk of death dying is 9%. So it's significantly high death rate. Yeah. And 3 to 5, which means all the curve points carry 1 in each, and so that is high severity, and that has a death rate as much as 40%. So that is very high risk of dying. So that is the bad pneumonias. So coming to the pathogens, what are the organisms we come across? The commonest will be like Streptococcus pneumoniae, or what we call pneumococcus, and also Klebsiella pneumoniae, Staphylococcus aureus, H. Haemophilus influenzae, Legionella pneumophila, Mycoplasma pneumoniae, and the Chlamydia species. The Mycoplasma pneumonia, as I mentioned earlier, has very much in the form of extrapulmonary manifestations, which can be in the form of skin rash, liver involvement, and there can be arthritis, arthralgia, as well as hemolytic anemia. So these, when you see any suspicion, when you have any suspicion of these things, you should suspect atypical pneumonia like mycoplasma. So coming to viruses, the common viruses are like influenza viruses, which are seasonal virus infections causing pneumonia. So we have type A influenza and type B. And then we have parainfluenza viruses and the respiratory syncytial virus, the coronavirus, nowadays the hot point, hot topic people are talking about, and also like which manifesting in the form of classic syndromes described earlier. Apart from the COVID-19, the present endemic we are facing, the SARS and the MERS viruses previously called. We had those epidemics earlier, many years ago, and it's still going on in certain areas. But currently, Corona taken over a lot of cases of like COVID-19 related respiratory illness. Other common viruses like adenovirus and the cytomegalovirus we are having in the immunocompromised, particularly HIV people. There are parasites too. What are the parasites? These are rare parasites like strongyloids and the toxoplasmosis, which can be in the form of like lung abscesses commonly. Then we have another this is the same thing I mentioned earlier, like the community-acquired pneumonia with the curve score and the place of therapy, preferred treatment, and the alternative treatment. Coming back to the drug treatment there. So the low severity people can be, I told you, can be managed even at home but preferably we manage them in the hospital anyway. They can be given even the oral amoxicillin or intravenous amoxicillin, which we don't have commonly. Actually, what we have is coamciclav or the coamciclavulinic acid. So that's what we have in this setup. And the alternative treatment also can be doxycycline orally or the clarithromycin. The moderate severity group should always be kept in the hospital till they improve, and they are given again IV coamciclav. The alternative drugs like doxycycline, levofloxacin, or moxifloxacin, which are fluoxetine, which both are called macrolides. They are called macrolide antibiotics. Sorry, they are called quinolones. I made a mistake. They are called quinolones. The high severity group has a score of 3 to 5. They should always be managed in the hospital. And the preferred antibiotic will be the IV clarithromycin or IV coamciclav. The alternative antibiotic is levofloxacin. But in our setup, we in a country with high prevalence of TB, we are very careful to use these quinolones like levofloxacin or the ciprofloxacin for the pneumonia. So we spare those antibiotics for TB, and we don't use them very often, right? Unless it is really indicated. Also, the patient should be given the supportive care apart from antibiotics. So, what are the supportive measures needed? Obviously, as they develop fever, they need paracetamol to keep the blood temperature low. And the anti-inflammatory drugs are indicated for the pruritic chest pain. The drugs such as uh, ibuprofen and the diclofenac sodium or even COX-2 inhibitors, the currently used, and they are the inflammatory drugs which are of benefit. If oxygen saturation is low, oxygen wear face masks is needed, uh, and nebulization will be beneficial in the presence of bronchospasms, particularly using the salbutamol, respiratory solutions, or the protopium bromide, or the steroid preparations called budesonide can be used. Cough mixtures are also of use in cases of like those who are having a dry cough, which exacerbate the chest pain, and cough suppressions sometimes of use. And the mucolytic drugs are of benefit when they have thick, tenacious sputum to make it more expectorant. So that is the reason for the mucolytic agents. If the organism is identified in the blood or by any other antigen tests or whatever I mentioned earlier, uh, for the pneumonia, streptococcus pneumoniae, the drug of choice is, as I mentioned here, the amoxicillin, cefuroxime, coamciclav, or even clarithromycin. The Mycobacterium pneumoniae is particularly sensitive to clarithromycin and the doxycycline. The chlamydial species also the same, clarithromycin or the doxycycline. Doxycycline will be the drug of first choice. Legionella species again treated with fluoroquinolones, I mentioned earlier, ciprofloxacin, levofloxacin, and again clarithromycin also used. Haemophilus influenzae again treated with coamciclav, cefuroxime, cefotaxime, and ceftriaxone. Those are the third generation cephalosporins. Cefuroxime is the second generation cephalosporin. So cephalosporins and the coamciclav are the drugs of choice for Haemophilus influenzae. Further, if the organism is a gram-negative enterococcus, again the cephalosporins are of use, second and third generation drugs, as I mentioned, cefuroxime, cefotaxime, or ceftriaxone. Pseudomonas aeruginosa, particularly commonly seen in certain scenarios like those with diseased lungs, especially with bronchiectasis or the chronic obstructive pulmonary disease, or the lung fibrosis. So these organisms are sensitive to ceftazidime as well as gentamicin. So the ceftazidime or gentamicin, the combination can be used. The doses of which I'm not going to discuss here. You can always, refer the pharmacology books for the doses. Staphylococcus aureus, there are two types we come across: MRSA, methicillin resistant Staphylococcus aureus, or the methicillin sensitive one. So the non-MRSA one is flucloxacillin. The MRSA type, uh, vancomycin is the drug of choice. Aspiration pneumonia is always treated with coimosiclav in combination with metronidazole uh, because of the anaerobic cover. Pneumonia of immunocompromised. There are tuberculous bacilli as well as non-tuberculous bacilli. Uh, as I mentioned earlier, TB is very common in this country. So anybody with tuberculosis also will be screened for HIV nowadays. So this is a routine thing now. So this has to be kept in mind. So TB also a form of a pneumonia, though we classify it as a different entity, but it is a kind of a pneumonia, chronic pneumonia with lung fibrosis. And there's an interesting organism called Burkholderia pseudomallei, which is not uncommon in our part of the world, which is causing milioidosis. It's actually this organism can affect any system, any part of the body, including the brain, skin, lungs, liver, kidney, spleen, bones, anywhere. And it is a kind of a saprophytic organism in the soil, which is transmitted to the humans by various means. So that has to be kept in mind. There are fungi causing pneumonia in the immunocompromised again. The pneumocystis jirovecii is one of the common types of the pneumonias which you come across. Also, there are fungi like Aspergillus, Cryptococcus, and the Candida. Then there are viruses. If I mention few things about the pneumocystis jirovecii pneumonia, earlier we call it pneumocystis carinii, and that's why I put it as PCP also, but it is now called jirovecii, not uh, carinii. It's called jirovecii. So this organism has a particular pattern in the lungs, causing consolidations, which involve the lung in the form of is bilateral, infiltrative kind of a shadows in the form of bat swing appearance. That's a common pattern, but there are atypical patterns also. But this is the pattern of pneumonia, and they get very much oxygen desaturation in the form of exertional hypoxemia. So that is how they manifest clinically. Just to remember that. There are viruses. Cytomegalovirus, as I mentioned earlier, which can cause severe pneumonia, especially in the HIV people. The herpes simplex, also not uncommon to cause pneumonia. And the varicella zoster, another one. That is the chickenpox. And coming to the less common parasites, as I mentioned earlier, strongyloids and the toxoplasmosis. All these are seen in the immunocompromised. How do we treat these organisms? The jirovecii pneumonia, pneumocystis jirovecii, is sensitive to cotrimoxazole. Cotrimoxazole is usually used in combination with the steroid. So that is cotrimoxazole plus prednisolone. Then antifungal drugs for the fungal pneumonias. The commonly used ones are the itraconazole, fluconazole, and the amphotericin B. So these are the antifungal drugs. The problem with antifungal therapy is the hepatotoxicity, and the amphotericin has a lot of hepatotoxicity as well as cardiotoxicity. So these patients on amphotericin, of course, should be carefully monitored for arrhythmias and the other complications of hepatitis. Antiviral therapy, uh, cytomegalovirus, particularly we are concerned about here, or the herpes simplex. Herpes simplex viruses can be treated with the acyclovir, and the cytomegalovirus we commonly use a antiviral drug called ganciclovir. So, what are the complications of a pneumonia? It may be comic-acquired or otherwise. The common complication can be even form of a pleural effusion, as I mentioned to you, when there's a reduced chest expansion and there's a dullness on percussion. The clinical suspicion will be with reduced breath sounds on the same side. The patient may be having a pleural effusion. And so that is one of the complications. And also you can see there's a chance of developing a lung abscess, and then the rare complication, but more deadly or more dangerous, can be empyema-thoracis, the pus collection in the pleural space. Each of these needs a specific type of management, which I just touch upon. And also the pneumonia generally resolves with on its own or with the help of antibiotic therapy. It resolves usually within a course of maybe 1 week or 2 weeks time. It should resolve. So any reason for the unresolution or the delayed resolution, we have to take it as some problem with the either diagnosis of the type of pneumonia, or whether there is some other inadequacy of the antibiotic therapy or the wrong drugs being given for that management of pneumonia. So all these factors should be taken into consideration. If there's a small pleural effusion in the as a complication of pneumonia, we don't have to do anything. It just resolves on its own. Or if the effusion is significant, filling maybe 1/3 of the pleural space, then of course you might have to think of aspiration. Might have to do what is called uh, pleural aspiration, right? And if there's a lung abscess formation, again, you don't have to do anything most of the time, but use the appropriate drugs, and might have to sometimes intervene and aspirate the lung abscess. So the aspiration again may be needed in such a scenario. Empyema-thoracis usually needs an intercostal tube drainage. So we put an intercostal tube to drain the pus because pus is so thick, which is difficult to aspirate, and so that may be needed in some scenarios. This is a chest X-ray of a patient with moderate pleural effusion. You can see that is filling a significant volume in the chest, and so this appearance here with concavity facing medially, and you can see the fluid seeps up on the lateral aspect of the pleural space, and this appearance is due to the pleural fluid. And the underlying there can be a consolidation, which is not now as obvious because of the fluid overfilling the entire side there. This is the lung abscess. So you can see the lung abscess again, and with somewhat thick wall here. And so this can be a simple lung abscess, or even this can be even a misdiagnosed tumor which has been breaking down. So there's a bronchial carcinoma malignancy, and this is there, and the fluid. This is called fluid level. So this is the hallmark of a lung abscess. All right, then of course, how do you prevent pneumonias? Can the pneumonias be prevented? Yes. How do you prevent pneumonias? Pneumonias can be prevented by vaccinations. So there are vaccines available for certain types of pneumonias, not all the pneumonias. So one example is the pneumococcal vaccine, which has been produced with a pneumococcal polysaccharide material, and it's called PPSV223, and it should be given to all people age over 65 years. That's number one. And also it is given to the immunodeficient people. Also given to people with chronic obstructive pulmonary disease who exacerbate very often. And also to people with diabetes, which can be considered. And also people with other immunodeficiency status like cirrhosis and CKD and the splenectomized people. People's spleen has been taken out. This has to be given every once in every 5 years, and so that is the case of pneumococcal vaccine. And we have another vaccine called Hib vaccine, that is Haemophilus influenza type B vaccine, that is for the Haemophilus influenza. And that is again indicated for people with chronic obstructive pulmonary disease, as well as those with spleen being taken out, and those with again immunosuppression as a result of bone marrow transplant, and those with HIV and all those things, because they are immunocompromised. Then we have a common vaccine which is not readily available, but we also give in this country, that is called flu vaccine, flu jab. That is uh, seasonal flu, right? People develop influenza, I told you, type A and B. So there are vaccines according to the types, and this has to be given during prior to the seasonal flu, and it should be given annually. So how do you manage ultimately all these scenarios? So the management of pneumonia will include the prevention among vulnerable, as I discussed now. Recognize those people who are prone to develop pneumonias, the elderly more than 65 years, those who are with diabetes, CKD, and the chronic respiratory disease, and those who have been immunocompromised due to infections like HIV. So recognize them and vaccinate them. And also we diagnose the pneumonia early. So we have to have adequate suspicion, and then we diagnose this early and treat it. So give the appropriate treatment with antibiotics, and also advise them to do maintain the healthy living, like not to smoke, and to have their diabetes under control, and also get treatment whenever there is exacerbation of cough and having cold. Then you have to treat adequately, and also not to take a lot of alcohol. The alcoholism should be avoided all the time. So that is the health advice we can give these people. And once they go home after treatment, even we should follow them up adequately just to see whether they recover adequately and whether they develop complete complications even subsequently. So that is the idea of being followed up, right? I think with that I have sort of covered most of the things, and I wonder whether we can take any questions or we can just leave now. Thank you.
Thank you very much, sir. I will contact you for the time for the next lecture, sir.
Thank you. Yeah, thank you then. All right.
Thanks.
I'll send this to the mail.
You have my email address, sir?
Yes, the same thing you contacted me the other day.
Yes.
Yeah.
Yes.
Right.
Yes.
Okay. Thank you.
Okay. Thank you.
Thank you.
Okay.